Okay, we're live on YouTube now. Thanks, Chair.
Okay, thank you all very much for attending this morning and welcome to the Live Well South Tees board meeting. Have we got any apologies for absence?
Yes, Chair, we've got apologies from Frank Kilmurray, Councillor Mika Smiles, Sue Butcher, David Gallagher, Dr. Ali, Jason Law, Tony Parkinson and Deidre Fowler.
Well, it's hope to goodness you wrote all them down because there's too many of them. Right, any declarations of interest that we've got? Board, you know the way to do this. If you want to speak, I don't know whether we've got a hand up there where you can come in if you want to. We're getting a lot of feedback here, guys, so if you're not going to talk, can you turn your mics off so that we don't get too much interference? That would be good. Can we confirm the minutes of the meeting on the 3rd of September? Just raise your hand, please. Thanks, Dorothy. That's great. And seconded. Thank you very much indeed. That's great. Right, we're going to go on to the agenda now, and it's the development item, and it's addressing the inequalities. Mark, I understand you're going to present this, are you?
Yeah, I'll try and share my this presentation on the screen, hopefully. Can people see that?
Yeah, it's up, Mark. That's great. Thank you.
Okay, I'll just move you out of the way. So this intends to sort of brief the board on health inequalities, the impact of COVID, and what we might want to do about it as a board, as a sort of platform for discussion about that. So health inequalities, first of all, define our terms. Unfair and unavoidable differences in health across the population between different groups within society, largely as a result of the conditions in which people are born, grow, live, work and age. So they're structural. Quite often gets talked about in terms of choices and lifestyle choices, but they're actually structural differences that cause health inequalities, not choices people make. Quite often people can't make the same choices across all elements of society. And health inequalities result in poor health being experienced from a younger age, high intensity in a greater proportion of life, and ultimately premature death, as you'll see in some of the figures that I'll show here. So the overlapping dimensions include economic deprivation, so unemployment, low income and deprived areas of which people will be aware in both Middlesbrough and Raker and Cleveland. We've got quite a lot of geographical inequality as a result of economic deprivation. Then there's specific groups, particularly mental health, learning disability, homeless people, as it's got detailed there, vulnerable groups, but also BME populations and inequalities that arise as a result of some of the groups that people are associated with, protected characteristics which fall under the equality duty around age, sex, religion, etc. And then there's also inequalities caused by geography. So access to services in rural areas is quite often different or more difficult than in urban areas, and there will be other different challenges as a result of where people live, caused as a result of differences in those situations. In terms of the Northeast inequalities, as you can see, I have to keep moving you out of the way so that I can read these. The blue figures are the male differences in life expectancy between the wealthiest and the poorest in those council areas, and the pink is the same for women. So you can see for Middlesbrough it's around about 12 years for both. Difference in life expectancy. So the poorer if you're brought up in a poor area or brought up in a poor family, your life expectancy is 12 years less than if you grow up in a wealthier family. And Raker and Cleveland is 11 years for men and just over 7 years for women. And the Northeast is one of the, as people will be aware, is one of the poorest areas in the country and has some of the most difficult issues in the country. And just in terms of the NHS, the NENC is Northeast North Cumbria Integrated Care System, which people will be aware is will form part of potential changes to the NHS landscape, but their existing 5-year strategic plan talks about improvements in health outcomes, healthy life expectancy and patient experience, and there are some other issues for the health service to consider, which I'll come on to, and some areas and progress that we've made to date already around smoke-free trusts. We've got public health consultants working in NHS trusts, but not locally, but that's something that we might want to address, and I'll come on to that. Social prescribing helps connect people to services in a much better and more holistic way than particularly those in the most complex of circumstances. We've had the Deep End network of GP practices working into those areas. That was a programme from a few years ago, and I think has started up again recently as well. So that just sets Middlesbrough, Raker and Cleveland's position in context with the rest of the North East. Just in terms of this is deaths from all causes under 75. So this just puts in more context for both of the areas. So the graph on the left hand side of each graph is the more wealthy areas or the less deprived areas, and on the right hand side is the most deprived. So you can see there's that social gradient, and very similar pattern to other graphs that we've seen around things like admissions for self-harm, admissions for alcohol, and various other things. COPD admissions, I think, was another one that we saw, and has this same severe element of inequality in the very poorest in our communities. So the circles, the green circles represent wards, and they move along the x-axis dependent upon the level of deprivation in the ward. So there's a social gradient, and then when you get to the most poor in our society, it really has an impact in terms of the numbers of deaths relative to others in society that are wealthier. So you can see there's a gradient, but then a real severe gradient, a really severe issue when you get to the poorest in our society. And very similar graph from deaths from causes considered preventable, which compares death rates for specific diseases against the national averages. And again, you can see exactly the same kind of picture there, where there's a gradient, but also a really severe end to that of the poorest in our communities. The contributors to the gap in the length and the quality of life are pretty well known. So this is the percentage of the gap broken down by specific diseases that have caused those early deaths. So the blue figures are, and there's women and men in those two bar charts. Circulatory diseases, so heart failure and heart disease. Cancers make up the next biggest chunk of that explanation of those deaths, and then the green is respiratory. And I think for men particularly, you can see external causes here. This blue 111 is largely around accidents, where you can see it's bigger for men, is largely around traffic accidents that drives a lot of those figures. And I think it includes things like suicide as well in there. So one of the issues with inequalities is actually drives a lot of NHS costs and other costs. I think we can take the NHS as an indicator of how it drives other costs across crime and social care and various other partners with their health and wellbeing boards. So emergency hospital admissions, you can see that there's a gradient there, and again this more extreme end of the poorest in society accessing care as an emergency, and a more than twofold difference between, this is just for Middlesbrough, more than a twofold difference there between North Ormsby as the poorest ward and Cader as one of the wealthier wards in terms of accessing care as an emergency admission. And you can see the area that where that covers. So there's a sort of geographical inequality represented by that, and this is further demonstrated on this graph, which shows average annual NHS spend by age and neighbourhood deprivation. So this comes from the Marmot 10 years on review. So the baseline, this is quintiles of deprivation. So Q1 is the poorest in society and Q5 is the wealthiest. 0 is the health service spend by the wealthiest, and then it's added on Q4, Q3, Q2 and Q1, and you can see that the large health service usage by the poorer in society. So inequalities has a cost to the services that we provide, using NHS as an example, but it applies across all institutions. And in this graph first, I think I probably first saw it about 15 years ago, the cycle of missed opportunities. So poor health creates an over-dependence upon hospitals, as we've seen, which results in insufficient investment in prevention, which then goes on to further create poor health, over-dependence on hospital, and so on and so on and so on. So resources are invested in the acute sector because of the demand that's driven by the lack of investment in prevention and support for people to improve their health in other ways rather than accessing it at the acute end, be that as an emergency or as an elective. In terms of the NHS again, and I'm just using this because we've got figures for the NHS, but it applies equally for some of the other agencies. 20 years difference in good health. So this is not life expectancy, healthy life expectancy. There's a 20-year difference when you look at healthy life expectancy compared to just life expectancy. And the estimated cost of the NHS of ill health resulting from health inequalities is £5.5 billion a year. So significant. And significant enough that we should be looking to consider what we can do about it. The NHS has a legal duty under the Health and Social Care Act and the Equality Act, and numerous NHS plans and strategies have talked about reducing health inequalities. And there's a legal duty on the health service too. There's a form of words that's used. It's not minded to reduce health inequalities, but it's some duty that has some weasel words in it. But there is a prescribed duty for the NHS to play a role in reducing the impact of health inequalities. So just briefly to look at the impact that COVID has had. So we're in the same storm, but we're not in the same boat. So early on in COVID, there was a sort of we're all in it together type narrative because Boris Johnson was infected and Prince Philip and various other people got COVID. So we're all equally at risk and all equally experiencing this pandemic. But that's not the case. As you can see, the graph on the left is the mortality rates. The top of that is the quintile 1, which is the poorer in society, and at the bottom is the more wealthy. The green bars are male, and the sort of burgundy bars are female. And you can see that social profile again, where the poorer you are, the more likely you are to have died from COVID than if you're wealthy. And the blue graph on the right is from September, which is patients that are critically ill by deprivation quintile. And again, on the right is the poorer in society becoming more critically ill. And that comes from increased vulnerability because of the poorer health that we've seen in the previous slides, increased susceptibility because of the sort of greater stresses of living in that environment, increased exposure from job roles and contacts, so less likely to be able to work from home and reduce the contacts they have with other people, therefore reduce their potential exposure to COVID. And then more likely to be living in housing spaces that have got more shared spaces, more higher numbers of people, either be it through living in flats and shared lifts or shared entrance spaces. Therefore, an overall sort of picture that makes being poorer makes you more susceptible to both getting COVID and having a poorer outcome from having COVID. And there's a sort of broader impact of COVID. So there's the direct effect from being infected with COVID and the potential health impact that has. There's also the indirect effect from not being able to access or presuming that you can't access health and care services, particularly during the first lockdown period, and the impact that will have had on kind of more standard care. Indirect effects from social distancing and vulnerability, isolation, those sort of issues impact on mental health that we've talked about before. And then the longer term impacts, which is part of what was, I guess, the sort of political discussions around going into tier 2 and tier 3 and the economic support that was available for businesses during the shutdown. And I think we've seen in a previous presentation, the impact on jobs will hit the younger particularly hard, because hospitality industry and those businesses that are going to struggle particularly are those that are more likely to employ younger people. So all of that wrapped up hits the poorest in the community harder than others. And this is Sir Michael Marmot, who wrote the landmark Marmot Review in 2010 and the follow-up 10 years on in 2020. And he says, we've witnessed a social gradient in mortality rates from COVID-19. The more deprived the area, the higher the numbers of deaths. The social gradient is almost exactly paralleled by the social gradient for all causes of death. It suggests that the causes of unequal COVID-19 outcomes are rather similar to the causes of inequalities in health more generally. So in effect, COVID has just exposed underlying health inequalities and made them more acute because it's a more acute situation, but it's just the same as all the other causes of deaths that are impacted on by people living in poorer circumstances. And I guess the fundamental point to make is the evidence base for recovering from COVID and health inequalities are in Marmot's original recommendations anyway, which I'll come on to. So there's quite often discussion about is it the economy or is it health? And actually, economy and health are all interlinked anyway. So this is quite an old graphic about ill health and impacting on worklessness, impacting on productivity, which in itself impacts on less growth, fewer jobs, and people potentially being unemployed. So health and the economy are completely intertwined. And this sort of binary view of the world, that do we choose the economy in terms of considering lockdown, or do we choose health? We need to consider both at the same time because they're both interlinked, and you can't actually consider one without considering the other. So how we do that locally is something we probably need to consider. So in terms of how do we progress and what action do we need to take? Well, we maybe should listen to the Pope. And other religious leaders are available, obviously, but he said in his book, Let Us Dream, The Path to a Better Future, we need economies that give to all access to the fruits of creation, to the basic needs of life, to land, lodgings and labour. We need politics that can integrate and dialogue with the poor, the excluded and the vulnerable, that gives people a say in the decisions that impact their lives. And we need to slow down, take stock and design better ways of living together on this earth. So I think the critical bit about that is that the Pope was clearly talking about the population intervention triangle, which is an old friend of ours, which we've seen before, and which we're trying to base more of our work on and be consistent in the way that we consider and approach issues. So considering interventions at a civic level around policies across all the organisations within the place, and how they impact and improve health inequalities, or at the very least don't make them worse, and how those policies can improve health and reduce inequalities. Looking at the service level interventions, particularly around unwarranted variation and potential differences in access to services that can make those inequalities even worse, and how we work with communities to understand their needs, their requirements, and what assets they have that can actually help to an overall sort of co-created and combined way of improving things. And he's taking the Pope's quotes, the basic needs of life, land, lodgings and labour is around civic level interventions, and giving people a say in the decisions that impact their life is at the intersection between civic and community, around strengthening community actions and people's voice and people's feeling that they have a voice in the communities within which they live. So just picking three of those areas, land, what did he say? Land, lodgings and labour. So employment is obviously absolutely vital. If you were to do one, I think Michael Marmot said this, if you were to do one thing to improve public health, it would be to give everybody that was able to a good, well-paid and secure job. And as people will be aware, there's been a shift to more people in insecure jobs, 0 hours contract, and there's 1.5 million nationally in 2015 in 0 hours contract. I presume it's more now. And of those 1.5, just around about half, it was their main job. So it was their main source of income was a kind of unreliable hours and inability to shape that or have, I guess, basic employment rights. So tackling insecure employment is absolutely critical to how we work. And to an extent, it's perhaps not quite as stark as this, but to an extent, insecure employment has ended up as the people that are holding the risk. The risk there's been a sort of trickle down of risk to people that are the ultimate providers, the key workers, the frontline workers. So if you think of something like the cuts that happen to local authorities, cuts have been made to local authorities. We either outsource or more aggressively commission services. Think of something like home care. And then we get private sector providers, and the logic is that they're more innovative and all the rest of it in terms of how they provide things. Ultimately, there's a limited amount of innovation that you can have in something that is a person supporting another person to perform the sort of functions of life. And then that risk gets passed down to the person delivering the care in terms of low pay and potentially insecure employment. And I know both council areas have tried to take steps to improve that, but ultimately that's the sort of path that a lot of national policies have happened, that the person holding the risk at the end of the day is the person on the insecure contract, and the person who during COVID we were out the front of our houses clapping, but they're the ones that are bearing the brunt of both COVID and before COVID, the issues where we've been trying to take cash out of public sector services. Housing is obviously really critical, both in terms of best start in life and access to education. So that could include things like broadband availability within the house, but also decent home standard. As it says there, 1 in 3 homes in the private rented sector are not decent standard. And we did quite a lot of work in Redcar and Cleveland through a members task and finish group through scrutiny. So it's a slightly better picture in Redcar and Cleveland, but still an issue, particularly those people where we originally started the work looking at the term rogue landlords and how can we deal with landlords that perhaps don't treat their tenants the way that they should do. And then having gone through the work, we realized that there was it's not a particularly good term, but almost the equivalent rogue tenant, who was the tenant who had no more choices left to them because they'd either built up debt through other places that rented. They couldn't get into social housing because they'd been a poor tenant in effect. And then in that situation, you've got a poor tenant with a poor landlord, and the tenant has no agency, can't really assert their rights, because if they do, they'll just be turfed out and somebody else will come into their place. So there's a whole raft of work that both council areas are doing around selective licensing, landlord charters and things like that, but how and more opportunistic visiting of properties. There's some work in Redcar and Cleveland in Carlin Howe looking at trying to sort of support people by visiting them rather than waiting for them to complain, because we know that they don't have the agency, as I've discussed. So there's a whole raft of things that we can do and we should be doing around ensuring people are able to live in housing that supports their health and well-being. And finally, access to land, as the Pope said, is, and I'm sure he was thinking about its importance on people's ability to be physically active. People living in deprived communities are 6 times more likely to have no previous experience of outdoor activity. And obviously being active and it just being part of your life and living in nice areas where it's nice to go to walk out from your front door to a place that's reasonably accessible supports people to be more active. And the Sport England local area is really working with all this and working with planning authorities and working with transport to try to improve general access to green spaces and public spaces, and how we make those more accessible and better spaces in themselves. So I won't go into any more detail on that. So where does that take us to? So we've got a number of recommendations. So we've got 3 recommendations for consideration in terms of setting off pieces of work from today, and 2 to add to existing work streams. So the first is to adopt a social value charter across anchor organisations, and I'll come on to that. Second is to apply an inequalities impact assessment to key policies across partners. And the third is to develop whole systems monitoring and strengthen accountability for inequalities across the system. And I'll come on to each of those in a sec. And then adding to existing work streams, best start in life is critical to breaking the cycle of inequality. So through that work stream, committing to aligning priorities and activities across partners working on early years. And then the second one, looking at system-wide adoption of approaches which take financial crisis as a call for help, replacing sanctions with coordinated multi-agency support. And some of this is happening already. Stop the Knock in Middlesbrough is looking at aligning services that support debt and being more supportive to people that are in that situation. The kind of national policy of people that are in debt, particularly around council tax debt and other debts, is they get taken to court for not paying the debt and then get a fine loaded onto the debt, which they can't pay either. So it's taken a more humanistic approach to debt, and understanding that the making that situation worse obviously impacts on people's mental health, as was discussed in the last Health and Wellbeing Board. So I've just got 3 slides to talk about each of those recommendations, and then come back to the slides saying what they are for a discussion. So the Social Value Charter was developed in Raker and Cleveland, building on some work that was done in Liverpool, and covers employ local, buy local, think local, a great place to live, and good employers. And I think most organisations will be doing stuff through their procurement channel around employing local and supporting local businesses, and the Social Value Charter just looks a little bit more broadly than that. So it's around considering training opportunities and linking into existing initiatives in each area, like Foundation for Jobs and 50 Futures around youth employment, and how our procurement can actually encourage whoever wins the procurement contract. Part of the evaluation of that is their ability to employ more locally, to consider local training opportunities, and actually to use the power of the resource that we're spending on procuring a specific thing to actually also have more thought and be more thoughtful for the impact locally, and how we retain resources as locally as possible. And then buying local is thinking about their supply chain, so developing dense local supply chains of businesses that further support the local employment. So it's not only the whoever it is that wins the procurement process, but also the people that they work with through their supply chains. The Social Value Charter commits them to thinking about that through all of their business. And then how they might play a part in local communities around partnering with VCS and considering what volunteering opportunities they might be able to give within their businesses, what skills they might be able to share, and then considering their impact on what the place is like to live, protecting the environment, minimising waste, and so on. And then finally being a good employer and considering welfare of staff and those within supply chain. So it's broader than just the procurement approach, but also the other thing that we need to consider through this work stream, should we adopt it, is how we kind of assure ourselves that, having won the procurement, that the businesses are actually implementing what they've said they would do, because I think there's a little bit of a gap between signing up to this and whether it's actually happening in practice. So we need to consider how that happens and how that plays out. Second recommendation is on the Inequalities impact assessment. So this is a piece of work that was developed to support the recovery process in both areas, particularly health and wellbeing recovery process, but it applies to all policies. So we've tested it in some of the recovery plans in Middlesbrough, and it's a systematic approach considering policies against the Marmot recommendations of giving every child the best start in life, enabling children and young people to maximise their capabilities and have control, creating fair employment, and creating healthy and sustainable places and communities. So this will be about applying an inequalities impact assessment to key policies within all organisations within the Health and Wellbeing Board, to ensure at the very least that those policies aren't going to broaden inequalities, but even better, where we can make tweaks to ensure that they're cognizant of inequalities and can, by their implementation, can improve the impact of health inequalities. And finally, whole system monitoring, considering an inequalities focus. So this is a NHS example, but could be considered across all services. So in terms of patient groups, where are the inequalities around access, stages of presentation, processes and outcomes? Consider the shift to digital that's happened across COVID and the reduction in face-to-face contacts for obvious reasons. How does that exclude people, and what might need to be done to reduce that exclusion? considering inequalities further up the pathway as well, around prevention, early detection, diagnosis. Where do these inequalities show themselves? And that'll be around access to service, health-seeking behaviours, and all those sort of things, and understanding why some people present late, and particularly around cancer, but also all other illnesses. We've seen the previous slide around people, the poorer you are, the more likely you are to access care as an emergency rather than in a planned way, and that produces more poor outcomes and costs more. And then considering what social barriers that there might be to accessing services around finance, transport, health literacy, and other barriers, and also how does the specific service that we're considering fit in with other services, other agencies across the pathway that people might access. So how do we establish something that considers across the whole system how the services that we're providing are impacting on inequalities positively or negatively, and how do we amplify the positive and reduce the impact of the negative? So I'll pause there and put back up the recommendations at place level. So it's recommended to adopt the social across anchor organisations. So that's key organisations within the place that are on the health and wellbeing board, but also extends to organisations like the university and other big employers and big spenders of public money, and how do we keep that resource in the South Tees area, or at the very least within the Tees area, to increase the impact that has. Understanding how we can ensure policies positively affect inequalities, and then how do we develop whole systems monitoring to assure ourselves that is actually what's happening. I'll pause there, Mary. Sorry, that's quite a trot through health inequalities.
That was absolutely fascinating, but painting a very grim picture over the decades, and it doesn't seem as if we've got a grip on this and where we are at the moment, financially, not just for the health service, but for the local authorities. Everybody is at a low level with that, with funding coming in from government. However, the recommendations, Mark, that you put forward here, we've got to get a grip of this, and we've got to work across all partnerships with it if we're going to make a difference. Redcomb Cleveland have started a lot of that work, and we are looking at that for jobs and evaluating who we're bringing in to do these, and making sure that they are employing local labour as much as we can with this. And that is being monitored, Mark, and it does seem to be having some sort of an impact. But this is very worrying on the health streams, and I think it's going to be small steps, Mark, where we are in order to get hold of this. But if we don't get hold of this, in 5 years' time, you're going to be back here saying to us, this is how we are, this is what we were like in 20. We didn't grab those opportunities that we could get to work across the board, to work across local authorities, and to do what we can do. But it's critical, and I think that's really good, and I thank you for that presentation. Steve, you wanted to come in?
Can you hear me? Yes, sir. I'd just like to make a few points relating to this. I don't think low income per se necessarily has a massive effect on life expectancy. I do, however, think that insecurities of employment are in fact very relevant to this. A lot depends, in my opinion, on style of life that people adopt, and nothing much is actually being said about this here. I do agree about the housing stock. I think that in the UK, housing is of a very poor standard, having travelled abroad and seen what they've got. And it certainly needs addressing, but it will be a massive task. I don't agree with Mark about what the Pope was talking about, incidentally, when it comes to land. I don't think he's talking about urban parks and such like. Remember, the Catholic community is probably at its strongest in South America, where you have something like a feudal system still existing. In this country, before the Industrial Revolution, land was wealth. In these places too, land is wealth, which is why they're cutting down, unfortunately, the rainforests in South America. So I think the Pope is linking wealth with land. He's not advocating that we all have a park at the bottom of the road. So I think I don't agree with Mark's interpretation there. Mary's quite right about the failure to address and deal with this problem. I remember when I was in the Boy Scouts over 60 years ago, I got my public health badge. And to be honest, there were so many of the same things 60 years ago as they are now. Ever since I've been on the council, which is about 41 years, this 11-year gap between, we'll call them the rich and the poor, just for simplification, this 11-year gap has never altered. And I'd like to know, we do a lot of talking, but are we have any effect at all through the NHS and Public Health South Seas and the councils on reducing inequalities in health in our area? And I just sometimes think our policies are not sufficiently effective.
Thanks, Steve, for that. Mark, do you want to come back in?
Yeah, thanks, Mary. Well, I guess is the Pope's probably inscrutable, is he? So his interpretation is his interpretation. But I'm quite happy to
Well,
take.
he said it in the first place. You've got to take his interpretation.
Yeah, the reason I didn't talk about lifestyle choices is because the point I made about inequalities being structural. Marmot calls that lifestyle drift when we start talking about structural issues affecting inequalities around housing, employment, and the other things that you've referred to, and then boil it down to individual choice being the issue. And I think the critical thing around that is we don't all have the same choices that we can make, and generally the wealthier you are, the more choices you have. So in terms of something like smoking, if you're in an area where and you're 12 or 13 and all your friends are smoking, then you're more likely to smoke. So that's not necessarily an informed choice as such, but that's the way that it gets interpreted. So I don't agree with lifestyle choices at all. I think inequalities are structurally driven that then get framed as choices, because then society doesn't really have to think about it too much. And in terms of Steve's point about nothing's changed, well, not a lot has been done at a national level to address this. In fact, the last 10 or 12 years of austerity have made it a lot worse, and austerity has impacted a lot more on the poorer in society than it has the wealthier. And in fact, since COVID, the very wealthy have made a lot of money out of the various things that have happened. So we're fighting against national policies that make this situation a lot worse. And what I've tried to outline here is action that we can take locally to do as much as we possibly can to impact on the issues that inequalities cause. I'll pause there, Mary.
You're absolutely right, Mark, about that. And but we've got to do our bit locally, across the whole organisations, and we've got to come together and we've got to be joined up. And this is a massive task that we've got here. However, you pick certain aspects of that and you go for it. And this isn't going to happen overnight. This is going to be something that we are going to have to work on over years, Mark. But we've got to make a start somewhere. And I absolutely agree with you. So we will do that, and we'll do the best we can, and let's see if we can influence government down in Westminster. I rather suspect we will not. I'm sure all the local authorities in health, we've all been on to them about funding, that we need to work smarter. Barry, do you want to come in?
Thank you, Chair. Barry Cooper, Councillor for Newport and Gresham area of Middlesbrough. Some people do refer to my ward as being deprived, and when I think about this, I always think of housing, diet, lifestyle, personal hygiene and employment opportunities. I noticed your social value charter, Mark, that you mentioned does pick up on a place to live, so that comes in with my thinking of housing and good employers, again, employment levels. I was interested when you mentioned the Marbot recommendations about giving every child a best start in life. Now, to me, a best start in life is a good place to live. It's also health services and education. Well, we're building houses all over the place, so hopefully, eventually, the older housing stock will go and every child will have a decent house. Health services, we're doing the best we can with everything we've got, and I can't knock the NHS at all. I think they've done a marvellous job, especially in this pandemic. What I am concerned about is education. Education, we seem to be building houses at one end of the town and putting our schools at the other end, and I think we need to come out of that situation now and start planning for the future. If we're putting in a housing estate with loads of young children in it, surely we should be putting a primary school there as well, so that the children have a safe walk to school. If the area's got more houses, more children, we should be thinking about secondary schools, again, so the children have a safe walk to school. We shouldn't have all these buses and Chelsea tractors running around, because they're increasing congestion, they're increasing the carbon emissions, they're doing everything wrong towards us making ourselves a better place to live. And to sort this out, I think we need the education authorities to look at it, because let's be honest, local authorities have very little to say about the education of the children. It's all down to the Department for Education. And if they thought about it and looked well enough into the future, rather than sticking with the same old system all the time, I think we'd end up with a much better place for our children to live. Thank you, Chair.
Barry, I think that there's a lot of that down to the local authorities, both to Middlesbrough and to Wrekin Cleveland. We can decide where these housing are going. We can decide what we need in there and where the schools are, and we can influence, and we do have an influence. And I think sometimes, Barry, what we do is we let things slide without looking at the bigger picture, without looking at the picture for health, for education, for environment where we are. And we need to get a grip of that as local authority leaders and members going forward with that. We have to and work tighter with the NHS and make sure that we're more joined up than what we are, because I think sometimes we do things and then you look at it and you think, well, actually, had we done that, that would have worked better with schools and environment and everything else. So we do have a choice, Barry, and we've got to make our voices heard with this. Mark, do you want to come back on what Barry said there?
I think I agree with everything that you said. It just illustrates the importance of policies on health. You know, so it's not all those things play. If you can walk to school and it's a nice walk and a safe walk, then that impacts on your health and gets you in the habit of walking to places rather than driving to places. And it's all part of what makes well-being. So all of those things are really important, and that's the aspect of council's business that where well-being needs to be, and its impact on well-being needs to be a fundamental part of that those decision-making processes. So I completely agree with. I think Barry's just illustrated the sort of structural nature that I was talking about, and how we can potentially work differently by considering things in a different way to ensure that any developments that we do approve benefit our local communities more than perhaps if we didn't think in that way.
That's smart. Mary, did you want to come in?
Yes, Mary, I don't know whether you can see me or not or anything. I've had technical difficulties as ever. I'm in on my phone and I find some of the functions are missing. However, I'd like to go back to the last councillor who spoke and said about education, because I think it's very much linked with education, and we've been going on about this for years, but it's training people for the jobs that are out there. And I do think it is linked to low wages, low income, and you get into that lifestyle, which we have been trying to shake off for years and years. Members of my family have been involved with healthy eating, healthy living, and all sorts of exercise regimes. And it's very difficult to reach some people, although God knows all the authorities try. So we've got a task ahead of us, and that's perhaps why we want a slightly different approach. With regard to open spaces, I think I'm at odds with Steve this morning. Just, I don't mind what the Pope intended, who knows exactly, but I do think it's absolutely vital that people have open spaces and somewhere pleasant they can go. If you're stuck in a high-rise flat, say, with a family, with a titchy bitch of grass outside and nowhere to walk to, for me, it would be absolutely soul destroying. Thank you, Mary.
Can I have, Mary, can I have a point of personal explanation? I
You can,
fully
Steve.
agree that people should have parks, playgrounds, open countryside. I think it's all brilliant for health, mental as well as physical. But I do not think that's what the Pope meant. That's all I'm doing. I'm interpreting the words of the Pope. Usually when we look at religious figures, we very rarely know what they actually meant. Just have a look at the New Testament, for example.
Sorry, Steve, I never thought that you were against play parks and everything else. But I just said it, it's regardless of what he was intending. I agree with Mark. It is, key that, and for even those people who live in the high-rise places or crowded accommodation, then we need to have ready access for them to at least get to these places. Thank you.
Thanks, Mary, for that. We don't live in an ideal world, do we?
Sadly not.
Yeah, there is. We have an unfair society, and I think everyone would agree with that, no matter which side you're on with this, Steve. And I think the religious leaders do make remarks about things, but it's up to us to see if we can change our own environment that we've got locally, and go forward with that. Because if we don't, I live in a gorgeous place, rural. I walk out the door, I can see the cliffs from here, I can see the moors from here. I step away for 2 minutes and I'm in a green area, wooded area, but other people don't have that. And I know what you're saying, Mary, about the flats, but that's down to us, isn't it? That's down to local authorities. That's down to the choices that we made. And it needs,
past
we need to
mistakes,
change.
Mary. Past mistakes. I
Yes,
too am
past
fortunate.
mistakes.
I can walk to the beach within 5 minutes. I can get into Kirkleatham. Quarter of an hour, I'm into Kirkleatham village. What more can you ask for? But a lot of people, as you say, are not so fortunate, and those are the people we need to be taking care of. Thank
Thanks,
you.
Mary. Caroline, I don't seem to have anyone else that wants to speak. Have you got anything on there? Because there's nothing coming up on my screen.
I've not got anyone else, Mary. That's in message to say that they would like to speak. I'm just conscious that we've got some people on the phone who may wish to speak. So in order for them to unmute themselves, I think they need to press *6 on their phones, and then they should be able to speak. So I don't know whether you want to give anyone a minute in case they want to say anything on the phone.
Yeah, that would be great. Is there anyone who wants to come in? We'll just give you a minute and...
Caroline, it's Dominic. Do you mind if I just ask a comment?
Who's speaking, sorry?
It's just Dominic. I'm just wondering.
Oh, yeah, Dominic. Yeah, sorry, Chair.
Hi, Ed. So, Mark, thank you for the presentation. It's incredibly powerful, and obviously chimes exactly with the presentation last month in terms of mental health and well-being. One of the things you mentioned earlier was around public health consultants working within the NHS. And apologies if I missed it, but I think you'd said you were going to go back to it, but I'm not sure if you did. Would you mind outlining what you see has been some of the key positives and benefits of that?
Yeah, it was. Sorry, Mary. It was more that there's an opportunity to get, because we don't have a public health consultant in South Tees. I know there's one with Tees Esconway Valley. Edward Cononga is based in Durham and Darlington area. So they're looking more at the population health management side of things. So I think in Durham they connected some of the I guess the council information around debt, domestic abuse, various other things like that to the health service information when they originally looked at the vulnerable people who might be shielding or maybe should be shielding, and what support they could offer them through the COVID, through the hubs that were available, so that kind of sharing of data and sharing of how things could work was driven by Edward in his role as a public health consultant, as I understand it. I guess the other areas that I've looked at is supporting smoke-free sites and things like that within those settings. But I think if we can, there's some funding available. I think we have to bid for it for a public health consultant. But if we can bid for one and have a focus on inequalities and reducing the impact of inequalities locally, then that will give us some real additional capacity to do some of this work to drive this forward. So it kind of fits within that holding the system to account bit as much as anything else around the population health management and how we take metrics across all different agencies to get a better picture and understanding of what's happened that helps us plan services in a way that reduce inequalities rather than make them worse. So I think that's the kind of intention of that role.
Dominic, did you want to come back?
No, thanks. That's fine. That's really helpful. I suppose what I would comment is in terms of the work that Edward's doing, it is very Durham focused. So there's something about how we pull internally within TUV, how we pull some of that learning across to the Tees patch.
Thank you very much. Caroline, I don't appear to have anyone else in.
Oh, sorry, I think Eric wants to speak. Eric Swallows raised his hand, yeah.
I did very briefly, Chair. It was on the back of what Mark was saying, but Dominic's kind of touched on it. I think we could spend a lot of time talking about the extent to which disadvantage is a structural thing. I think there's plenty of evidence that it absolutely is, and I think that although lots of our policies and initiatives over the years have been targeted at reducing inequalities, I think looking at some of the evidence base that Mark looks at and that Edward is kind of generating, not all of it is kind of intuitive. And I suppose for me it would be a plea that we work more on the basis of the evidence base that's kind of quite well established. I think I talked to our public health consultants, I talked to Mark, and there's an extraordinarily well established evidence base about what actually works in terms of tackling inequalities. And I don't think we use the evidence quite as much as we should. And that might take us towards a position where, you know, hypothetically, it's just thinking out loud, where when we're employing across all of our council activity, across all of the our kind of partners activities, it may be sensible that we have a sort of a lens, if you like, of some of the evidence that's there when we consider doing things around our environment, when we consider doing things around regeneration, around building houses, that we look at all of that through a lens based on the evidence about inequality and how to tackle it. And I think that might be the way that we start to see a bit more traction about how we work, rather than working on sort of gut instinct. Thank you.
Thanks, Eric, for that. Mark?
Yeah, and I think the health inequalities impact assessment, that's the intention of that, is that you use the evidence base to prompt the thought and the consideration and the questioning in a structured way, rather than, well, this might work. You know, as you say, there is a large evidence base. The kind of core source of it is the Marmot review, but there are other sources as well, Due North report and things like that, that help us understand that. So that health inequalities impact assessment is a way of, I guess, getting this across all key policies, across all organisations in time, and the impact that that will have will be based on a foundation of the evidence base. So I completely agree with that.
Thank you, Mark, for that. So can we move, we are moving these recommendations that have come from Mark. But Mark, what I want to know is, we haven't got another meeting until early next year. I don't want this left. I want you to be able to explain to us where we start with this, what we're doing with this. How many do you want a subcommittee sat on this to try and start to pull things together? Do you want other reports from the local authorities? So if you give us some direction on how we can work together, rather than wait till the next meeting and say, well, we've done that. I know it's Christmas, guys, but if we can pull something together to help to at least to start the process, Mark. So where do you want us to go?
Yeah, I'm all right with Christmas, Mary, because I've shifted it to June anyway, so that's all right, and we'll pull something together around an implementation plan about how we take each of these areas forward. We've got a good platform in each of those areas to build on, so we'll work an implementation plan, potentially take it through the health and wellbeing exec to get all the people signed up that will be doing some of this work, and then we can bring a report back on what we're proposing in terms of actually implementing this rather than just letting it drift, as you say.
Thank you, Mark, for that. I'm sorry about these phones keep ringing here. I keep switching them off. This something will be going on. So can we remove those recommendations from Mark? Are you all happy with that? There's no dissent with this. Let's get this moving. This board, we do have a lot of teeth with this, and I think in the past we haven't used the powers that we've got with this. We've got a mammoth task in front of us, but let's see if we can make a difference. Let's take small steps and let's see what we can do with that. So are you all okay with that? Yes? No dissent with it. Thank you very much indeed. Thanks, Dorothy. That's smashing. Thanks. Right, Mark, we've actually got you again, and it is for the COVID update for the South Tees area. Thank you.
Okay, thanks, Mary. I don't have any slides or figures for this. You'll probably be quite relieved to know. So the picture of the community infection rates in both, well, in Redcar are flattening and have been flat for the past couple of weeks. So we dropped dramatically from around about 500 cases per 100,000 down to around about 140, and we've stayed flat at that. So the rate of increase has slowed. Rate of decrease has slowed. In fact, we're not decreasing, and in Middlesbrough we're actually starting to increase again, driven largely by 25 to 34-year-olds is the main age group that they're actually going up, and the other age groups are pretty much flat, which is worrying because that's what we saw in September time, was that it started in the younger age group and then made its way through to the older age group and eventually hit the hospitals. The activity in the hospitals has reduced and is flattening again. So it's reduced from around about 20-25 new cases per day, either diagnosed in the hospital or admitted with COVID in the hospital, to around about 10. So it's significantly lower than it was, but still giving pressure on the NHS. I think there's around about 10 or 11 people in intensive care at James Cook. So I think the rates fell very rapidly, and it looked like national lockdown particularly was having a big impact. And unfortunately, they haven't fallen far enough, from my perspective, for whatever's going to happen around the Christmas period, and that's the critical time, the 5 days of Christmas, where you'll have families mixing, people staying overnight in families, which just potentially, if there's a person infected within that situation, in effect, most of those people will probably be infected with COVID. So it just amplifies the effect, and I'm worried that we'll see the rate of increase that we saw prior to national lockdown, where we got up to, as I say, to 500 cases per 100,000, and the impact that we started to see on the NHS. So January is one of the busiest months for the NHS anyway, and the impact of that Christmas period is going to be critical. So we're working in both areas on the comms, how we amplify the national comms about people, I guess, enjoying Christmas as safely as possible. In addition to that, we've got the pilot community-led testing happening in Grangetown starting today, running for 5 days, to see how, I guess, to understand what the demand for testing is. This is asymptomatic testing using the lateral flow devices, to understand what communities think of that, whether they'll show up for it. And we've done a lot of work to try to generate that demand, but we'll find out this week what the appetite for testing is. Both areas are looking at opening up that bigger testing regime, as you've seen in the national press, around about mid-January, to give us a good planning run at it, and also to allow us to learn from other areas that have done it, because the financial modelling relies on numbers that are tested. So the income that we get to support the costs is based on the numbers tested, and the actual costs we receive are a little bit unclear, but starting to become clearer with the collaborative agreement that was released on Friday. With both areas have signed up to be part of the local tracing partnership. So we're both pulling details that the national system of cases that they're unable to contact. That went live on the 9th of December, and we're also part of a pilot to pull those cases sooner. We get them after 32 hours, which is a little bit too late, really, but we're looking to pull those and get access to them immediately, because that'll have a big impact, as we've talked about before, that we can actually have a dialogue with somebody that's more than just telling them that they've been diagnosed as positive, but talks about the support that's available to help them to isolate, which is the critical thing in terms of breaking those chains of transmission. So a whole raft of activity. We're gearing up locally between Christmas and New Year to make sure that we've got as many contact tracers in locally as we possibly can, such that if we do start to see the numbers rise, we can contact people and get that support wrapped around to support isolation of cases and their contacts. The issue is that only works when the general rates are lower than they are at the moment. Once the rates get quite high, it becomes quite difficult to determine where the infection was generated and get other people to isolate in that situation. So we'll have as much capacity as we can to respond to that in between Christmas and New Year and in early January. But that's the main risk in terms of COVID, particularly on obviously the health and wellbeing, as we've talked about, in terms of inequalities, but also impact on the health service in January. I'll pause there, Mary, because I could probably go on for quite a long time.
Thanks, Mark, for that. And I think we're all very concerned about what central government have done for over Christmas. Yeah, I can see, Steve, I'll fetch you in a minute. And I think it's a mistake. I think we are going to see our numbers going. Redcomb Cleveland started to drop, Mark, but over the last few days, we're still getting those numbers in, which is a little bit worrying. And we've got further numbers in this morning. Here, I think it's in its 20s. I know we're doing the testing in Grangetown at the moment. But my main concern is what's going to happen with the tiers. I've got Lord Bethnal tomorrow, and then on Wednesday I've got the Minister to tell us which tier we're going into. I know our MPs locally are pushing to drop into tier 2, and that was the ghost of the conversation that was happening on Friday. Whether they will do that, because what I seem to be getting from the Minister was that we needed to stay where we were initially. And I know that they're on about the mass testing, that's logistic, Mark. There's a lot more to sort out about this going forward. So, Steve, I'll fetch you in.
Yes, thank you, Chairman. I just think that the local MPs, the Conservative ones, are just playing to the gallery, to be quite honest. I think it would be, in my opinion, a big mistake to go down, is it up or down into tier 2? I think, from what Mark has just said, about the rates rising, particularly in Middlesbrough, and flattening it perhaps in Redcar and Cleveland, there's no justification on the figures to go into tier 2. And I think when the Minister looks at this, he will keep us in tier 3. What is even worse, Mark did mention this briefly, these 5 free-for-all days which Boris and his fellow First Ministers throughout the UK have given us over Christmas. All the experts are now coming out to say that there'll almost certainly be a spike, a further spike, caused by this. And I think it's a national disgrace that the governments all over the UK have gone in for this strategy. It's a strategy of disaster.
Thanks, Steve, for that. Mark, did you want to come back? Have you got any comment on that?
No, I think that's that's quite right. I guess the only thing is that we're doing everything that we can to mitigate that. It's just quite limited what we can actually do to mitigate the rates once they start escalating in the community. But having looked at what we're planning, I don't think there's anything else that we could do locally to mitigate against that.
I guess, yeah, I'll fetch you in, Dorothy. I guess, Mark, this is about common sense. It's a virus that's spread easy. However, if you follow the rules, you can't spread it. And this is we keep putting this out to the public with media, with the NHS have done a video and everything for us, and people aren't listening, Mark. And I don't know, from a health point of view, how we can get that across further. Dorothy, do you want to come in?
Good.
I think I got the gist of what you were saying there, Dorothy. You were a bit Dalek-y. The rates in the schools are coming down in Redcar and Cleveland, but going up a little bit in Middlesbrough, which reflects the community transmission. We haven't seen a huge amount of kind of amplification of numbers through schools. So generally, when bubbles have isolated, people that have isolated as contacts, we haven't seen many people then become cases. So I don't really see schools as a place that has amplified it in the way that you perhaps might expect it to have done. But having said that, I think that the holidays and the reduced mixing of school staff, pupils, should have a positive impact as long as the mixing is less when they're at home, which is necessarily the case. But I think the schools would just reflect the communities, the rates and the communities within which they operate, really.
Mary, do you want to come in?
Just regarding the schools, I know that a couple of years at Ings Farm School are likely to be out to what will take them to the end of term. And this always seems to be the case of there might be an isolated person within the class. And I do know 2 children that were tested and they were both negative, fortunately. But also, it's the schools seem to have been more affected by staff taking things in than the children themselves. Of course, they're asymptomatic. But lockdowns don't always work because they have stricter rules in Wales. It didn't seem to work because they're escalating after we come out of their sort of fire break, and their staff do use masks and face masks throughout the day. It's just, you know, accepted. So I'm not quite sure what the answer is. And the other one was, sometimes you look at the figures and you see isolated areas that seem to be higher than others. And I know that's certainly the case with in Kirkleatham ward. But you need to look what's sitting in those wards, whether it's, you know, care homes or other institutions. So it's a very difficult picture to identify what actually does bring about any increases. But I tend to agree that we need to be very careful over Christmas. And I'm not bothered whether we just stay and be, although I know it does adversely affect businesses and pubs and what have you. And you know, I overheard someone saying they oh well, I'm not bothered. I'm going to do what I want at Christmas. And I thought, oh, for God's sake, you know, I kept my mouth shut. Anyway, thank you.
Thanks, Mary, for that. I think it's going to be difficult. I think, Mark, and I thank you for that, and your teams and all public health and everybody for trying to do what they can do. But I do think we're going to get a spike in January. I think that's exactly what's going to happen. And I think the government are being totally and absolutely irresponsible over what they're doing here. The majority of people around here where I live will not be mixing with other families, and they've been extremely good. But we do have people who, and as Mary said, and I've had quite a lot of them, and quite a lot of abuse on Facebook saying we'll do what we want and don't you tell us. So you're right, Mark, we can only do what we can do and hope for the best. The problem is these people who have been so belligerent about this, they're the youngsters, young men in particular that I've got, 20 to 30s, that they're going home with this. Because we had a spread in North Yorkshire at a working men's club that affected the whole of that area and shut it down through irresponsibility. Because they knew they were infected, they knew there was an issue when they went there. There was dozens of people turned up there, and it ended up with a 700 spread, which is absolutely ridiculous out into that community. So we are where we are. Mark, did you want to sum up with this before we go on to the next agenda?
I think you've summed it up quite well there, Mary. I think we're braced for what's going to happen in January. We're mobilising the sort of limited impact that we can have, and we'll look to understand what's happening and get comms messages out if it looks like it's getting away from us again. But they have limited impact as you've described. And I think if I was betting, it will make its way from younger people through to older people in the same way as it did in September, October time. And we'll do everything that we possibly can, which might include the mass testing, might be part of what helps us bring it down, depending upon the demand for that testing, which I don't think is necessarily a given. So I'll pause there, Mary. I think that's as good a sum up as I can give.
Thank you. Sorry, Craig, I've missed you. I see you'd like to speak.
If that's okay, Mary, yeah, I just wanted to highlight some of the fantastic work that James Cook over the last couple of weeks to get the the hospital-based vaccination program up and running. The program started last week, and the hospital have been able to vaccinate around 400 members of staff, patients, and care home staff each day since Tuesday last week, which has been fantastic. Really, I think we've had now nearly 400 care home staff vaccinated between Tuesday and Friday, which is a fantastic start. It's by no means the majority of the workforce or the population, but it's a great start, and I think they've made the best possible use of the limited number of vaccines that they've had available. So I think James Cook needs to be congratulated for that work and the support they've offered to the broader system in making sure that it's not just hospital frontline staff that are receiving the vaccine, it's care home staff as well as some of our most vulnerable patients.
Thanks, Craig, for that. And yes, of course, they do. Do we know, Craig, have you heard anything about the Oxford vaccine? I know that they were looking at it and they are trying to give it its certificates to get that rolled out. I thought it was going to be happening this week. the vaccine that we've got at the moment, bearing in mind it's got to be down at -70, creates all sorts of other issues, Craig, for the hospitals and GP surgeries. I spoke to my GP the other day because they thought that the GP surgeries would be able to roll this out. However, what they're saying is that each patient coming in for this vaccine, they've got to be kept there for 15 minutes to see if there's going to be any reaction to that. That hasn't been possible for either the local hospital up at Broughton or for the doctor's surgeries, because it's causing all sorts of other issues that they didn't envisage with that. I understand with the Oxford one, it would be easier, Craig, to give, and because of its temperature. So what do you feel about that? Have you any other details?
This time we've had no further information relating to the Oxford vaccine, so just need to be really clear on that, Mary. But there has been developments in terms of some of the protocols and the cold chain protocols around the storage of the existing vaccine, which means it can be stored between 2 and 8 degrees C for a range of up to 86 hours, so up to around 3 days, 3.5 days. So that does make it a little bit more manageable. But unfortunately, we've not heard anything further yet about the Oxford vaccine. Like yourself, we're still waiting to see on that front.
Okay, thank you very much indeed, and congratulations to everybody. Mary, did you want to come in?
A quick call. We're giving the vaccination out to care home staff, and I think that's great, and congratulations to all that's going on at the hospitals and other settings. But is there any thoughts about providing domiciliary care with similar vaccinations when you consider they're out in the community, they're going in and out of different places? Thank you.
Craig, do you know anything about that? Or Mark, do you know anything about that?
Yeah, I mean, what I can say is at this time, the way the vaccine arrives and the way it needs to be stored makes it really difficult to support domiciliary visits and vaccinations being taking place in patients' own homes. So I think that's something that's continued to be looked at, and obviously the Oxford vaccine would make that a lot more straightforward. So at the moment, we're trying to work on the mass vaccination sites, so there's limited movement of the vaccine itself. But I can see Alan's got his hand up as well. Okay, Alan may have some further detail from a South Tees Trust perspective.
Thank you. Alan?
Well, thank you. I must apologise, first of all, for joining the meeting so late. No, I'm afraid I don't have an update on either the Oxford vaccine or on domiciliary workers. I just wanted to acknowledge the point that Craig had made. It's been a phenomenal effort at the Trust. You know, people have been up at 4 o'clock in the morning in order to defrost the vaccine to get it ready for delivery. That we've got is availability of the vaccine. So we are prioritising care home workers, patients who come to the hospital or over 80, and only those NHS staff who are frontline and potentially vulnerable. So, you know, the constraint is not our willingness to give the vaccine. As Craig said, we've got the capacity to deliver 400 vaccinations per day, but we're waiting on a daily basis whether we get the next delivery of the vaccine. It does seem to be in quite short supply.
Thank you, Alan, for that. And we do actually appreciate every single thing you're doing, as Craig said there, and our grateful thanks to the staff. I was rather concerned because what we were getting out of central government, Alan, was that this vaccine was available and it was flooding into the country. And then actually looking at the numbers of the vaccines that were coming in, although it was welcome, it was relatively small numbers that were coming in. And now what we're hearing is there is a shortage. So what worries me about this, Alan, is it's not, and we welcome the vaccine, of course, but of course you get politicians who come out and say, this is what we're doing, and we're flooding the country with this. And then, of course, the expectations from the public are that we have enough and we have enough vaccines and it's coming in on a regular basis. And actually, Alan, that's not true. So we're in this situation where the public are ringing me and saying, well, I'm in this vulnerable age, Mary, when can I get mine? So it creates different situations and difficulties for ward councillors as well as the local authority. Would you like to comment on that, Alan?
Well, I can't really comment on. I mean, I can't really comment on what politicians say or don't say at a national level. We all know that they want, particularly with government. But what we're doing at Trust is that we're through every possible route, make sure that we get the supplies of that on time and as quickly as we can get them. And there was the last thing that I seen this morning was from the tail end of last week. We're worried about where our next supply of vaccine was coming from, but I hope to get an update, and it will be that we've had a further delivery since. So it's that all we do is resolve the lines of inquiry that we possibly can. We go through national routes. We've got things at the Trust who are chasing this up on a daily, almost hourly basis to try and make we've got capacity to do something that we don't end up not, and particularly that we don't end up lining people up for that and they're having to cancel them, which would be the worst of all worlds.
Barry, do you want to come in and then I'll fetch Mary in?
Can I ask very, very quickly, is it still being sent down from the Newcastle hospitals? And the other thing was, what was the infection rate of people having COVID from within the nursing staff in James Cook? Thank you.
Alan, have you got any information of that?
Yeah, so as I think Mary's talking about patients catching COVID when they're in hospital. Is that am I correct in understanding that was the question?
I was thinking about staff. It relates personally because my granddaughter, who's in her final year of meds, has just got over COVID, and obviously she was visiting hospitals. So I was wondering how badly nurses and associated workers in the hospital are being affected. Thank you.
Oh, thank you. So the level of infection amongst NHS staff is about 3 times the average for the population at large. And we do keep an eye on it very closely, and we've got a significant number of staff always who are either self-isolating because they've come into contact with people who've acquired the virus or they've actually acquired it themselves. But at the moment, that appears to be manageable. If you take up absences for all reasons, about a third of absences are related to COVID, which in the circumstances, I think, it's not where you would ideally want it to be, but it's probably bad in the circumstances. And we're not at the moment that COVID is putting a huge burden on us in terms of not having the staff to keep going. And I would say I'm really a part of the conversation. We have seen a drop in the number of hospitalizations, the number of patients coming through, and there was a period of about 2 weeks going back another 2 or 3 weeks where we were at a peak in the second wave, and we've definitely come down from that. But we do seem to have plateaued and come right down from the peaks. The lot seems to have worked, but we'll continue to fall off in infections remains to be seen. A fall in infections result in hospitalizations and deaths. So I think from what I from the earlier part of the conversation, you probably share the same concern that expressed that good work has been done to get the infection under control. We're waiting nervously to see what happens when Christmas open up, and then what happens post-Christmas. Of course, we're in a slightly more challenging position than we were during the first COVID, because national instruction went out that we should concentrate on COVID and only continue to perform the most urgent non-COVID procedures. We're in a different situation now. All of our is going to the very maximum degree. That's a more complicated business because it means having to screen people very carefully through the different pathways in the various hospitals. I would say that morale actually high. The vaccination has given a boost to morale because it's a fantastic team effort. People feel good when they conceive as a result of really putting in hard work and working every hour. It leads to a positive result. And, to see the flood, mostly very young people coming through what looks a little bit like a MASH field hospital, if you remember TV series. Lots of temporary partitions in a theatre. It has been a great effort, and it has given a boost to the morale of the people working in the park, which is.
Thank you, Alan. Barry?
Thank you, Chair. I'd just like some clarification on how long the virus can live outside the body, because the vaccine will protect the person who's had the vaccine, but that doesn't mean to say they shouldn't continue to social distance. They could still carry it on their hands or whatever and still infect other people. Am I right in thinking that they live outside the body for some time? Thank you, Chair.
Alan, do we know?
I think there's still some uncertainty as to precisely, well, first of all, how effective the vaccine is and how quickly it's effective, because it's a vaccine that's delivered in 2 doses with a gap of about 3 weeks or something in between. And the advice given to have the vaccine is that they should continue to observe all the same restrictions that the rest of us are observing. It's not as if this gives you any kind of immediate free pass to socialise or resume activities that were normal before COVID. I will have to wait for further evidence about quite how effective it has been and continues to be. I'm not an expert in any sense in virology or the life cycles or how long it remains active. See that lots of the vaccine trials have been extremely positive, but we need to get it to a very large number of people before it will have a significant impact on the prevalence of the virus in the community.
Thank you very much indeed for that. We have one last agenda item, members, and it's Health and Being Exec Chair Report. Dr. Ali, and I can't see him. Oh, Catherine?
Yes, hi Chair. Dr. Ali Tamsib has actually had to send his apologies to the meeting, so I'm quite happy to quickly go through the report. Most of it's for information, but quite happy just to summarise it. Is that okay?
Thank you, Catherine.
Yeah. So the report just summarises the work of the Health and Wellbeing Executive, which kind of looks at the progress that the board is making in terms of delivery of its statutory obligations and the priorities within the board. Obviously, the executive meets on a monthly basis, whilst the board meets quarterly. So we try to make sure that we just keep track of progress. Just in summary, Chair, in terms of statutory functions, the Better Care Fund, which I think has been around probably for the last 4 or 5 years, which the Health and Wellbeing Board is responsible for oversight and signing off. We haven't had, when the papers went out, we hadn't had any kind of policy framework or planning guidance issued around the monitoring and assurance of this year's programme or next year's. But since the papers went out, we've actually been notified that the Better Care Fund will continue into 2021 and will continue up until March 2022 at a Health and Wellbeing Board level. And we're expecting some policy framework out in the early new year. So hopefully at the next meeting, we'll be able to give the board some details around what that policy framework is and what the programme is for the future years. But within the report, we've summarised some of the progress that's been made in year with the Better Care Fund schemes. The other section looks at the pharmaceutical needs assessment. Normally, we would update the board on any amendments or new changes and new pharmaceutical needs assessments, but due to COVID, the requirement to publish renewed P&A has been suspended until April 2022, so we'll continue to provide updates where necessary. Healthwatch South Tees, which is the engagement element of the Health and Wellbeing Board, has provided a summary of its engagement that's gone on through COVID. There's quite a lot of detail there that just for information that members can sort of read at the leisure. And in terms of progress against priorities, just skimming down to the towards the end of the paper, we've set out, I think, Dominic did a presentation at the last board meeting around the predictions for post-lockdown increase in demand for mental health services across the system. So following that presentation, Dominic and colleagues have worked on an action plan which has been drafted in a number of areas of the focus, which is summarised within the report. And what it's also suggesting is that the progress around the delivery of that work programme is overseen by the Mental Health Prevention and Crisis Concordat Group, and that will provide updates regularly into the Health and Wellbeing Board. And then finally, it's just a summary of a number of funding opportunities that the Health and Wellbeing Executive have had oversight of. One is around a green space social prescribing bid, which was put into NHS England just back in October, and we're waiting for the outcome of that to come to be announced. And then the other one was a bid that I think has been reported to the board in the past around the King's Fund Healthy Communities programme, which unfortunately South Tees wasn't successful for. But I think there's, because of all the work that had gone in actually preparing the bid, I think there's a commitment across the executive and stakeholders that to continue with the plans that it set out and potentially seek some funding opportunities from alternative sources. So I think that's it in summary, Chair. If anyone's got any questions, but a lot of it was for information.
Thanks, Catherine. I really appreciate that. Dorothy, going forward for Middlesbrough and Redcombe Cleveland, I think we need to see what we're going to do for the meetings going forward, and we'll work alongside the officers in order to do that. What Mark's brought forward with his recommendations today is critical that we start to move them, even with small steps. But we will do that. Let's see if we can try and get a grip on this. But anything else, Dorothy, that we've got, we'll work with the officers, or if any of the members there have anything particular that they want to come to this board, then we need to get that to the fore. Our next meeting is on Thursday, the 25th of March at 2:00. I want to thank you all very much today for today's meeting. You all stay safe. Try and have a good Christmas as much as you can, and we'll see you in the new year. But all your health officials there, and Mark and Public Health and NHS, thank you very much indeed for what you're doing, and we'll see you again shortly. So bye-bye for now, okay?
Thanks, Mary.
Yeah.
Thank you. Bye, everybody.
Bye.